Hi, I'm Michelle Ginsberg. I'm a thoracic radiologist, and I'm Director of Cardiothoracic Imaging and Vice Chair of Education at Memorial Sloan Kettering Cancer Center in New York City. So how do we know when a CT scan requires intravenous contrast in the staging of lung cancer? Well, in general, the intravenous contrast, as the name implies, intravenous, is very helpful with vascular structures. And it enhances in vessels and also is very helpful with visceral organ enhancement. It can be very helpful in the enhancement of the tumor and delineate that tumor from adjacent, let's say, collapsed lung. And you would see in that case the tumor has a different vascularity from the adjacent lung. But more importantly, it's very important for the surgeon because it helps with invasion. And specifically, they need to know, is there vascular invasion? Is there invasion of the great vessels, of the heart, and what they will need to do to resect? So that's one of the main reasons why you need intravenous contrast, is in the delineation and involvement of the tumor in the preoperative patient. It's also useful in detecting pleural metastases if you have an effusion, because an effusion may mask the pleural nodules. With contrast, they may enhance and will stand out against the fluid. So it's helpful with that. It's also helpful in a lymphadenopathy. Now, mediastinal lymph nodes, because generally they're in mediastinal fat, you can see them without intravenous contrast. But of course, the contrast helps separate the vessels from the lymph nodes. Now, in the hilum, that's a little bit different because the hilar vessels, if you don't give contrast, are not opacified, and the lymph node is right next to it, and it will blend in. So it's really vital when evaluating hilar lymphadenopathy to give intravenous contrast. Now, often we image a patient through the chest, but we also get images up to the upper abdomen. We like to include the adrenals in lung cancer staging because often it metastasizes to the adrenal glands. And it helps to see, in that case, we also get images of the liver and spleen, and you may inadvertently pick up metastases there with the intravenous contrast. So certainly I would say it's very important in the preoperative patient to have intravenous contrast. Now, for the radiation oncologist, similarly, it can also be very useful to have intravenous contrast. Not vital, but useful. It may help them delineate it from the adjacent, let's say, collapsed lung. And they need to delineate the tumor from that and make the radiation field as small as possible. But if it all looks the same in attenuation, then that's difficult. Giving contrast will change the enhancement of the tumor versus the adjacent collapsed lung. The evaluation of lung nodule with intravenous contrast has been studied in the past. And there have been studies looking at the enhancement of a nodule, whether you can predict that it represents malignancy or not. Unfortunately, it's not helpful. So giving intravenous contrast to categorize something as neoplastic is not helpful because inflammatory lesions or infectious lesions can have a lot of vascularity as well and can enhance. But it helps with in characterizing a lesion as a vascular lesion. So if you're not sure if something represents, let's say, an arteriovenous malformation versus a lung nodule, in that case, it's extremely valuable and actually required. And that's how we characterize arteriovenous malformations with intravenous contrast and separate them from just a lung nodule.